Good morning, everyone. Morning. Awesome. Well, hello and welcome to our third annual Breast Decisions event. Thank you for joining us in our new hybrid format this year. Our top priority is the health and safety of our community, which is why we are glad to bring today's rich content to you here in person or from the comfort of your own home. For those of you newly acquainted with Orlando Health, we're a not-for-profit healthcare organization dedicated to improving the health and quality of life for the individuals and communities we serve. Founded in Orlando for more than 100 years ago, we now consist of 15 wholly owned facilities that are hospitals, as well as freestanding emergency departments, physician practices, cancer institutes, and rehabilitation services for both adults and pediatrics. Caring for our community is at the heart of what we do. And last year, we are proud to say that we provided more than $760 million in charity care, community benefits programs, and community building activities across our regions. Thanks. Yay. Shout out. The purpose of our event today is to bring awareness to breast cancer, including the importance of regular screenings, what to expect if diagnosed, and what to expect as a survivor. Some current breast cancer statistics. 1 in 8 women in the United States will be diagnosed with breast cancer over her lifetime. In 2021, an estimated 281,550 new cases of invasive breast cancer are expected to be diagnosed in women in our country, along with 49,290 new cases of non-invasive breast cancer. Breast cancer is the most commonly diagnosed cancer among American women. In 2021, it's estimated that about 30% of newly diagnosed cancers in women will be breast cancers. About 85% of breast cancers occur in women who have no family history of breast cancer. These occur due to genetic mutations that happen as a result of the aging process and life in general, rather than inherited mutations. The importance of having this event is to spread knowledge for current breast cancer patients, survivors, and their support teams. We are here to share the resources and information so you know what is available and reduce the fear and unknown regarding breast cancer treatment. We want to take this opportunity to remind everyone the importance to continue with regular mammogram screenings. A prescription is not needed for these and your insurance will cover them. At Orlando Health, we believe that quality and safety go hand in hand. We're dedicated to providing a healing environment that promotes health and safety. We require everyone at our facilities to wear masks and follow the highest level of infection prevention. Orlando Health South Seminole Hospital and the Orlando Health Cancer Institute are here to serve the community and make high-quality, state-of-the-art services accessible to anyone whose life has been affected by breast cancer. So thank you for joining us today. And I would now like to turn the page over to Jackie Atkinson, one of our incredible breast cancer patients, who will be moderating today's panel. Jackie?
Okay. So I can see you. Well, good morning. You guys look so lovely. This is wonderful. Well, hello, I am Jackie Atkinson, a breast cancer patient for Orlando Health, and I will be your host and moderator for today's event. Well, my journey began January 20th, 2020, and I was diagnosed with stage 2 ductal carcinoma breast cancer. Now, as my journey progressed, my Orlando team, and yes, it's a team, also progressed with more wonderful people added to treat, care, encourage, and yes, cheer me on to the finish line. Some of which are here today on the panel. Yes. They answered my plethora of questions, that is a lot, reassured me several times that my hair would grow back and my eyelashes, yes, several times, and that I would recover. They were my biggest cheerleaders. They did it. So while my cancer journey may be a lengthy one, it is not one that I walked alone. And I was well supported by my God, my family, my friends, and my Orlando Health team. Yay. As women, we put ourselves on the back burner to every other responsibility, don't we? We take care of everyone in our lives, but taking care of ourselves is critically important, and especially for our overall health. Well, this morning, we will hear a special presentation regarding self-care from Dr. Diane Robinson, followed by a panel discussion with physicians and experts from our oncology team. And at the end of the panel, we will have a time for questions. And if you are joining from home, welcome. We invite you to also ask questions as well. You may do so at any time by typing your comment using the Q&A feature at the bottom. It's located at the bottom of your screen. And at the end of the panel discussion, you will also have the opportunity to raise your hand and ask your questions. All questions will be monitored throughout and addressed at the end of the discussion. So additionally, whether you are joining from home or in person this year, you will be receiving an email with information on local resources and health tips. The communication will be sent Monday, October 4th, and will have a subject line, Breast Decisions 2021. So now we will begin, and I would like to introduce Dr. Diane Robinson, neuropsychologist, for your special topic on self-care.
Thank you so much for inviting me here to speak about a topic that's near and dear to my heart, which is self-care. We've heard a lot about this during the pandemic, and with good reason. It's been one of the most stressful times that we've ever experienced as a worldwide community. And when you add a cancer diagnosis on top of that, it's really become so difficult and somehow more important to look at self-care. Things that once seemed incredibly important to us all have flipped over, right? Our perspectives have changed. And so I'm going to talk to you about three things this morning. One is simply feet, forks, and fingers, right? And then we're going to talk about activating your network. And finally, we're going to chat about kindness. We start our journey into self-care by that really catchy phrase, right? Feet, forks, fingers. I'd love to say I invented it, but I didn't. That's Dr. David Katz at Yale University. He heads up and founded the Prevention Research Center, which is fascinating. And a lot of the research I'm going to talk about comes from there. We all have actually quite a lot of control over what we do with our bodies, yet it doesn't seem that way at times, right? We kind of all know we should eat better and eat less and move our bodies, but that's hard. And it's even more difficult when you have a major health crisis like breast cancer happening to you. You have nausea, fatigue, and a lack of time and finances sometimes to really think that you can take care of yourself. But what we know from research is if you can remember feet, forks, fingers, it can go a long way to helping both your physical and mental health. So let's start with feet. Okay. Can we keep them moving just a little bit? Sometimes this is really hard, but let me tell you, fatigue is the #1 symptom that we get reported to during a cancer diagnosis. It's #1. Interestingly, the research tells us if we can just keep our bodies moving, it's one of the things that will actually help with that fatigue. And that's really difficult to do when you're just exhausted. So I'm talking about a little bit. If you can't get up, put on your favorite tune, dance in the chair. It's okay, right? we really need to understand that our bodies weren't made to be sedentary. And so no matter the effort, try and do this. Remember your feet, look down at them, right? And what about forks? It's an interesting one, isn't it? In general, eating right is a very powerful way you can help take control over your health and take care of yourself. Now, during treatment, we don't want you necessarily gaining weight or losing weight unless one of your wonderful panel up here is telling you to do that, right? But we do want you to nourish yourselves. Think about yourselves. Think about everything that is going on and the battle, the incredible energy your body needs to help you get through this. So by eating things that are going to nourish you, you're going to go a long way to taking care of yourself and sustaining yourself through this journey. And always, always, always remember to speak to your oncologist if there's foods that you should avoid. Have that conversation and reach out to a dietitian if you're not quite sure, okay? So finally we get to our fingers, right? What are we doing with them? Do we have a cigarette there? Do we have a glass of wine, bottle of beer? Or are we holding a paintbrush, holding a ball to throw to our dog or cat or grandchild? Or what are we? We have a lot of power there. Every day we can make small choices and actions to help ourselves feel better. But that can be hard, right? So who here has ever had a New Year's resolution? Who here has really kept it? We have these really fantastic goals, right? And it's so hard for all of us to make them, let alone when you've got a cancer diagnosis. And so part of that is we underestimate how hard change can be. It's really difficult. And so taking small changes, making small steps is really a powerful way to help with those goals that you may have. And the other really important way is that activating your network. And what do I mean by that? I don't have the pleasure of knowing you. So I don't know what is your network for you. You are the expert in you. Nobody knows you like you. And I don't know what your network is. It might be your family, your friends, your church, your work, your medical team right up there. But activating them. We are hardwired to interact with each other. And during the pandemic, boy, that was hard, wasn't it? Still is. But we can find new ways of doing that. And so when I say activate your network, it means pick up the phone. If you want to move those feet a little bit more, talk to your cousin across the country and say, listen, I need you to be my coach, as Jackie was saying. I want you to be my cheerleader. I'm going to try and walk around the block, but can you give me a call and help me out with that? And when your neighbor says, hey, remember that salad that you really loved? I'm going to make it for you. Say yes. Activate your network. Reach out. It's okay to ask for help. Now, some of you, I know, are sitting there going, well, that's all right for everyone else, but I could never accept help. I am never going to have my neighbors do that because I do for everyone else, right? We're the caregivers. It's really hard when you've been taking care of everyone else to actually say, yes, I'm going to take care of me. So that's when kindness comes in. Kindness starts with yourself. Kindness is letting other people do for you what you have been doing for them for so many years. It's when your natural instinct to say, when your neighbor says, can I cook you a meal tonight? And you're going, oh, no, it's fine. Saying yes, yes, actually you can. Start that kindness there because it's an important aspect of self-care, really understanding when it's just saying yes. And importantly, saying no when it matters. We all need kindness because we have endless chatter in our heads as human beings. We all do. I don't know what your chatter is, but boy, I've got a whole range of them myself, and I'm not fighting a battle. So those things that say, oh, you know, you can't show that you're weak, or your chatter's going on, oh, I'd never let people help me. I get you, they wouldn't, that wouldn't be right. Or I can't, I shouldn't, I must. All of those boxes that we set up and trap ourselves in, if we can open them up with kindness to ourselves and remember that thoughts aren't facts. They're just thoughts. Like today it may rain, or today you may have a thought that may come to you that, oh, I'm not going to make through it, nobody likes me, whatever it is. It's just a thought, not a fact. And so kindness starts right there by saying, it's okay, it's just a thought. And what can I do today to help myself feel physically and mentally better? Small steps. Remember, to make those new relations, we make small steps, small goals that we can achieve and slowly help ourselves go through this diagnosis. And I talked today about activating community. I want you to look at this community that's here. Around this room, there are amazing people with so many wonderful stories. You have a whole room back there full of resources that can help you. Talk, open yourself up for new possibilities. And remember always to think about what? Your feet, your fingers, your forks, activating that network and being kind to yourselves. So I hope today you will listen to this wonderful panel that's here and start to remember about taking care of yourself. Thank you so much.
Thank you, Dr. Robinson. Feet, fingers, and forks. That will be forever in my brain. Thank you. So now it is time for me to have the honor to introduce our wonderful panel of experts today. Down at the far end is Dr. Robin Rahm, surgical oncologist. Next, yay. Dr. Susan Constantino, medical oncologist. Dr. Cameron Swanek, radiation oncologist. Dr. Omar Baitis, plastic and reconstruction surgery. Ryan Bisson, genetics counselor. Marcy Pegg, oncology nurse navigator. And then Megan Euler, lymphedema therapist. Okay. So we're going to start with the questions with Dr. Is that me or you? Okay, okay. Thank you. We're going to start with Dr. Rahm at the end. So Dr. Rahm, I'm going to ask the questions on behalf of these lovely ladies and those who are watching. What can someone expect during their initial consultation with you?
Well, as a surgeon, I'm generally the first entry other than radiology into the patient's journey with a diagnosis of breast cancer. So a patient presents with an abnormal mammogram or concern on their exam. In the office, they'll be evaluated with history and physical exam. We determine if a biopsy is needed and what type of biopsy is needed. Usually, needle core biopsy is offered to the patient either by myself or radiology. And then we set up a follow-up appointment to discuss those results. Some biopsies need to be done by radiology under mammogram, and others can be done in a surgeon's office under ultrasound. Most patients do not go to surgery without a diagnosis from a needle biopsy. So that's the first step.
Okay, how do you determine if someone needs a lumpectomy versus a mastectomy?
Once we have the diagnosis of cancer, I then will order additional testing, such as a breast MRI. We want to see, is this the only lesion in the breast? Is there anything in the opposite breast that needs to be biopsied? And then it's mainly patient choice for the operation if one is a candidate for either mastectomy or lumpectomy. Most patients can safely be treated with breast conservation if they have early breast cancer. Also, the workup could include genetic history and testing to determine if testing is needed prior to surgery. But again, most patients that have a small lesion can undergo breast conservation if that is their choice. Certain genetic conditions would indicate a further testing and discussion.
So what is the average timeline of diagnosis to surgery?
We like to have patients undergoing treatment certainly within a month of diagnosis. Now that may sound like a long time, but rarely is someone ready to go to surgery the next week or the next day. As I said, an MRI is done to make sure there's only one area of cancer before offering breast conservation. So there's additional workup needed, and there could be other biopsies needed. So a simple, straightforward lumpectomy with all the information available at the time of their visit could theoretically have surgery the following week. Additional consultations are often needed with plastic surgery if that's a consideration. Genetic testing could be a consideration. So that's where the month out timing would come into play.
So if cancer has traveled to the lymph nodes, how do you determine how many to take?
There's several reasons we remove lymph nodes. One, the main reason is for staging the cancer, because if there is metastasis to the lymph node, that becomes a stage 2. And treatment could be different. So we want to remove the lymph nodes that the breast drains to, which is called the sentinel lymph node. And often it's just one lymph node, and sometimes the drainage is to more than one. I determine that by a mapping procedure during surgery with an injection of a radioactive dye in the breast and a blue dye. And that way I determine which lymph nodes drain the breast and those are removed. So hopefully we can take out as few as needed, which may be 1 to 5. If someone has cancer spread to the lymph nodes, it's going to be necessary to remove all of the nodes that have obvious metastasis. And then the remaining treatment can be radiation therapy. When patients have chemotherapy before surgery, because of known positive lymph nodes, those lymph nodes may respond to treatment and shrink away that we cannot clearly identify them. So at the time of surgery, I like to try to find 3 lymph nodes to remove to see if there's any remaining cancer.
What are some of the long-term side effects or complications that can occur with a lumpectomy?
Lumpectomy is rarely done alone as a treatment. Usually radiation therapy is part of that treatment. So the long-term consequences of the breast conservation will be some loss of volume of the breast from surgery, some decrease in size with radiation shrinkage and some fibrosis. There can also be some chronic pain in the breast, especially with compression such as a mammogram. The other side effects are related to the lymph node removal, which can create some numbness under the arm, some sensory changes in the nerves that run down the arm and around the back, depending upon scarring in the armpit or lymph nodes removed and nerves disrupted. Most of that clears up, but some can be permanent. And there can be chronic pain from the nerve trauma as well. The other thing we see sometimes is lymphedema with removal of any lymph nodes. And there can be lymphedema in the breast as well. That can be managed by working with our therapists.
So what are some of the side effects and complications with a mastectomy?
With a mastectomy, the majority of, I like to say 98% of the breast tissue is removed from underneath the skin, and that is extended throughout a rather large area where the breast is supposed to be anatomically. So the skin will be numb where the breast was. There are more likely sensory changes in the armpit and down the arm with this surgery. There can also be chronic nerve pain. And if there is not reconstruction, then obviously there's the tissue loss and defect. Lymphedema is a problem with mastectomy, just as it is with removing lymph nodes with a lumpectomy. With reconstruction, there can be added pain in procedures from multiple surgeries, and Dr. Betas will be able to explain that in more detail. The choice between breast conservation and mastectomy is a complicated personal one, and with patients making the decision on what they feel they need in conjunction with recommendations from the care team.
So what does someone need to know regarding discussing a preventative mastectomy if there is a strong family history?
Family history alone is not an indication for preventative mastectomy in most cases. When there are multiple relatives with breast cancer at an early age, generally premenopausal or under age 45 to 50, there should be a referral and consideration for genetic testing for a gene panel that would look for the most likely genes that contribute to increased breast cancer risk. Patients that have one of the main genes can consider preventative mastectomy. The other option for those patients is screening with mammogram alternating with breast MRI, such that one is done every 6 months, and then monitoring. When patients have relatives, such as their mother and sister and aunts that have had breast cancer, there may not be a gene mutation that we can detect, and there still is a family history risk. So most of those patients are followed closely. Sometimes we'll select patients for additional extended gene testing and see if anything turns up that way. But they can be followed in our high-risk clinic as well. If someone has a gene mutation, usually it is associated with ovarian cancer risk as well. So that would be a consultation with our GYN oncologist. And it's recommended the ovaries be removed sometime after childbearing because ovarian cancer is more difficult to detect. And then the preventative mastectomy would be offered when they're finished with childbearing and choose to undergo that procedure. The advantage of having that done before a cancer develops is most likely lymph nodes will not have to be removed, and we can prevent someone from having a cancer that could require chemotherapy. So that's what's considered in the decision making. Screening should begin 10 years before the first relative the age of the first relative's diagnosis.
Thank you. We will now move on to Dr. Constantino. She has a fan club. All right, the first question, I call her Dr. C, Dr. Constantino. When will someone first meet with a medical oncologist?
So that's variable depending, can you guys hear me? Depending on the situation regarding the patient's cancer. So usually the patient will have met with the surgeon initially, and then will either see me prior to surgery to discuss treatment options, and if treatment is recommended prior to surgery, or sometimes patients will see me after surgery when we have the results and can discuss their treatment at that time.
So what factors determine my need for chemotherapy?
So the need for chemotherapy depends on quite a few factors. It can depend on lymph nodes being positive, which used to be standard of care for all patients with positive lymph nodes, that they undergo chemotherapy. Now there's a test for some patients with estrogen-driven breast cancers called Oncotype that we can send with 1 to 3 positive lymph nodes, and that can tell us if a patient is likely to benefit from chemotherapy. So that's a really exciting test that has actually been able to spare some women from needing chemotherapy at all. The individual characteristics of the breast cancer, such as being triple negative or being HER2 amplified, those can also determine if patients need chemotherapy. Chemo is used more often in those cases.
So how long does it last?
Chemotherapy can last as short as 3 months or as long as 6 months. And with a HER2-driven breast cancer, patients will continue with IV HER2 targeted therapy for 1 full year.
So how often will I have routine scans to assess my cancer?
So we don't do routine scans. Those used to be done a while ago when we would do a yearly or every 6-month scan. But it found that there was actually no benefit to that, and patients were being exposed to radiation as well as cost and anxiety of undergoing those frequent tests when it wouldn't necessarily pick up on a recurrence. Now we do mammograms if you've had a lumpectomy, usually about 6 months after radiation, and then sometimes we'll do a follow-up in 6 months on the affected side, and then ideally get to yearly mammograms. As Dr. Ron mentioned, in some patients will do MRIs as well for surveillance, and we try to alternate those on a 6-month basis. So it's done once a year, but it's staggered from the mammogram, so that each 6 months we're doing some imaging with regards to that. Anytime a patient has a concern for metastasis or recurrence of their breast cancer, then we would certainly investigate that with appropriate imaging.
So how often will there be a follow-up or follow-up appointments with the oncologists during the cancer journey?
So routine follow-ups after treatment is completed, meaning like chemotherapy is done or radiation is done. It's usually every 3 months for the first year, every 4 months for the second year, and then every 6 months, years 3, 4, and 5. After that, patients can be seen yearly or can follow with their primary care physician. If they have concerns, certainly they would be seen at that time. But for routine screening follow-up, that's what we do.
What are some long-term side effects from medication, and how would they be managed?
So as many people in this room know, there are long-term side effects from treatment. Some of the more annoying things for patients are neuropathy, which if you've experienced it, it's very frustrating and can be a long-term side effect. For those who don't know, neuropathy is a numbness or tingling in your fingers or toes, and can be like a pins and needles feeling, or like that sensation you get when your arm falls asleep, leg falls asleep. But it can be permanent and it can be very frustrating. It can affect your ability to button shirts, or sometimes your handwriting can change, can affect your sensation in your feet, which can affect your balance. So that's one of the more common ones from chemotherapy. With patients who have estrogen-driven cancers that are on hormone blockers, they can experience hot flashes and joint pain or joint stiffness. These are the most common things that I hear about that are frustrating and annoying. Patients usually tolerate it because they know the benefit of the hormone blocking therapy, but it's not something they enjoy too
Amen. So, what is chemo brain and how long can it last?
Shall I defer?
Yes. Look at all the men, please.
So chemo brain is when you feel like you're, and it's a real thing, where you just don't have the memory necessarily for, like, you walk into the kitchen, you're like, why am I here? I joke that I have secondhand chemo brain, which has not been described in the literature, but I will be describing that. But yeah, it's just kind of a distraction or feeling a little absent-minded. I know they talk about pregnancy brain too when you're pregnant. So I think sometimes our brains are focused in other places. But chemo brain can last up to a year after finishing chemo. And you can do things to help with that, like having notes that you keep, or doing activities to help stimulate your brain. So things like word searches, crossword puzzles, jigsaw puzzles, things that keep your mind going.
Thank you. That's important. What is the purpose of long-term maintenance medication? And how long will someone need to take them? And is there a reason to stop early?
Great question. No stopping early. So the maintenance medications help to decrease your risk of recurrence. And those are based on the characteristics of your cancer. So if your cancer is hormone driven, or ER/PR positive, we call it, then there are pills that help to decrease your risk of recurrence. And those are things like tamoxifen or Remedex, Femara. And those are taken usually for 5 to 10 years, which sounds like a long time, but it is. But that decreases your risk of recurrence by about 50%. Now that's only for estrogen-driven cancers. So if your cancer doesn't feed off of hormones, then those hormone blockers really don't do anything for you. For HER2-positive breast cancers, there are targeted drugs that I mentioned that are given IV for 1 year. And then there's also a pill that's been approved for another year, which a lot of patients won't take me up on that second year.
Wonder why.
Blockade. But basically those maintenance therapies are aimed at blocking what's driving the cancer. And so we're decreasing the risk of recurrence and helping patients to live long lives.
So what are some common side effect signs that cancer is back?
So that can be variable. Breast cancer can come back locally within the breast, where you may feel a lump or a mass. It can come back in the breast where it's found on mammogram or ultrasound or MRI, in which case they biopsy it and investigate. If breast cancer comes back distantly, it tends to come back in the bones as one of the primary sites, and usually in the trunk region. So hips, back, ribs, sometimes even shoulders, but doesn't tend to be like knees or elbows or ankles, feet, hands. So that tends to be more arthritis or potentially a side effect from Arimidex or Femara. But if patients have unexplained bone pain that's persistent and progressive, we don't know why it's happening, that's something that we would investigate with either a bone scan or an X-ray or an MRI. So that's what I have patients look out for the most is bone pain, particularly in the trunk region. If cancer can come back in the liver, the lungs, other places in the body. And so I always tell my patients, if you're laying in bed at night thinking, that's my cancer, you need to call me, we'll figure it out.
Great, thank you. And we love you. We don't blame you for all the pain. All right. Next, we will hear from Dr. Swanek. So the radiologist. So when will someone first meet with a radiation oncologist?
So we like to be involved as early as possible. I think that our group here is pretty good about getting you in with us even before your surgery, because a lot of times, as Dr. Rom alluded to, the surgical decision is can be based on your willingness to undergo radiation afterwards. So for patients who opt for a breast conserving surgery, like a lumpectomy in most cases, with some exceptions, women will need radiation afterwards. So I'd like to meet with you, talk to you about what that means, the timing, the side effects, and make sure that that's something you're okay with before making that surgical decision. That said, I think we'll get into it. There are some indications for radiation after mastectomy as well. And so we like to meet with you early on because I think it's important to have some idea of what radiation is so that if you need it, you're not sort of blindsided by the 6 weeks of treatment and all of the everything that goes into radiation when you're already exhausted from your surgery and maybe even chemotherapy. So we like to let you know up front that possibility and what radiation entails.
Awesome. So what factors determine the need for radiation?
Yeah, so the main factor is what type of surgery the patient elected to have. So for patients who have a lumpectomy, almost always radiation is indicated to the remaining breast with the goal of reducing the risk of recurrence in that breast. For patients who have either a lumpectomy or a mastectomy, but who have positive lymph nodes, then I absolutely like to meet with them to discuss the pros and cons of radiation in that setting. In most cases, radiation will be recommended, but there are some patients for whom, if the lymph node metastasis is very small and a lot of lymph nodes have been removed, then we can discuss potentially not doing radiation after mastectomy. But you should always meet with a radiation oncologist in the setting of positive lymph nodes to have that discussion because it is rather nuanced.
So what is the radiation process like?
So once you've had your surgery, or if chemotherapy is part of the plan, we typically like for surgery and chemo to be done in whatever sequence Dr. Costantino and Dr. Rom recommend. And there's often a plastic surgery component of that too for patients who choose to have reconstruction. That's done generally before the radiation starts. Once you're done with either chemo or surgery, 4 weeks after, we would start the radiation, and it's anywhere from 3 to 6 weeks, depending on how large the area is that we're treating and sort of the lymph node status and other risk factors. The first step is a planning session called a simulation, and that's where we put you in the treatment position. That's when you get the very hopefully very small tattoos that come along with radiation that are permanent, but I try to reassure patients they're like a freckle and hopefully we won't really notice them too much long term. And then about a week after that, we start the treatment. So we're typically give you about 4 weeks to recover from either the most recent surgery or finishing chemotherapy before we actually start radiation. And then it is daily treatment for up to 6 weeks.
And you get really good at holding your breath. So can radiation be done more than once?
So that's a great question. We generally, as a rule, we don't like to do radiation more than once in the same area. So if for example, a patient had a breast cancer 5 years ago, we treated the left breast, they come back with the right breast cancer, that's not a problem, but it's a different area. In patients who do have a local recurrence after radiation, we can sometimes use radiation again, although we're very careful about it. Sometimes we elect to use proton therapy, which is a technology that we have downtown that can help in those settings. So it's definitely not off the table, but our goal is to kind of reduce that risk as much as possible the first time around so that we hopefully don't get in the situation where we're having to retreat the same area.
So you walked right into the next question. What is the difference between normal radiation and proton radiation?
So the two types of radiation are just a different, it's a different technique. It's a different type of energy in terms of the way that the radiation is delivered. The total dose to the target, the sort of the effectiveness, the reduction in risk of recurrence are identical between the two. But in some cases, there can be some advantages of proton therapy just because of the way that the dose is deposited. And so I know Orlando Health, we're very proud of our proton program and we market it quite a bit, but it's not perfect for everybody. And for breast cancer, the vast majority of patients, we get excellent plans with standard radiation and are actually able to that's often my preference. And then if there's a situation where a patient has really unusual anatomy or we're retreating them, then we have proton therapy in our toolbox, but it's often not the sort of mainstay of breast radiation.
Okay, what are the side effects of radiation and how long will they last?
Sure. So we divide radiation side effects into acute and late. So acute are things that happen during and in the few weeks to a month after we're done with treatment. The main side effect is skin reaction, and that can be very variable. So some patients are just a little bit pink by the end of treatment and others have a lot of redness and peeling. And unfortunately, it's not always easy to predict how, two different patients are going to react to the same dose. The good news is most patients do heal afterward in terms of the redness and the peeling, and they can go on to have, in some cases, fibrosis where the tissue is just not quite as soft as it was before. But then again, I have patients where I can't even tell what side I treated except for the little tattoos. So it can be quite a range of skin reactions. There is a little bit of an increased risk of lymphedema in patients who need the lymph nodes treated. On top of that surgical risk, that's a long-term risk. And then there can certainly be some effects on reconstructive outcomes for patients who need radiation. And we're careful about that, but our goal is to kind of reduce your cancer risk as much as possible and sort of accept that consequence on the reconstructive end, although we certainly try to think about both things. And then in general, with our current techniques, really low risk to heart and lung long-term, but those things are there, small risks of heart disease in the future. And so we do everything we can to minimize those doses to the heart and lungs during the treatment to reduce that long-term risk.
Mm-hmm. So how will side effects be addressed? Do you talk about them?
Yeah. So we see our patients every week during radiation. So that's actually one of the reasons I really wanted to go into this field. I thought it was neat that you get to see people, maybe not as frequently as Dr. Constantino does, but during the treatment, you see them once a week. And I have sort of a very specific schedule of creams, starting off with over-the-counter and escalating to prescription creams as we go, helping address any sore throat that can sometimes happen when we're treating the lymph nodes. And then certainly I see patients again in follow-up to address any long-term complications, but we watch you very closely during the radiation to help manage anything that pops up.
So how often are the follow-up consultations?
So that can vary just based on physician preference, but I like to see my patients a month after treatment just to make sure that the skin has healed and that there's nothing, and to kind of coordinate follow-up and make sure nothing falls through the cracks. And then I typically do a 6-month visit and a 1-year visit about 18 months after completion of treatment. And then from there, just kind of leave it up to the patient if they'd like to see me annually.
Awesome. Thank you so much, Dr. Swanek. So now we are moving on to Dr. Betas. So yes, clap. They're awesome. They put you back together. So first question, when should someone expect to meet with a plastic surgeon?
Great question. So typically the first time a patient will come meet with a plastic surgeon is soon after they made a plan with the breast oncologist about mastectomy or lumpectomy. We are, I would say, somewhat less involved in patients undergoing breast conservation therapy or lumpectomy because typically there's not much reconstruction to do. Later on, there can be some options like fat transfer where we would do liposuction of one area and then transfer that fat into the breast for some volume. But that is a much later operation done after your completion of all your treatments for your cancer. So typically, if you're undergoing a mastectomy, that's when a patient would meet with us, and that would be prior to the surgery so that the breast oncologist and plastic surgeon can coordinate the care. So
what are my options for breast reconstruction?
So the two main options for breast reconstruction are what we call implant-based reconstruction. So where we would use a saline or silicone implant or what we call autologous reconstruction, where we use the woman's own tissue borrowed from other parts of the body. That can be the stomach or the back or the thigh. And then we transplant that tissue or rotate that tissue into the breast to reconstruct.
So how does someone know which reconstruction option is right for them?
So that's a great question. I think for every patient, that decision is individualized and unique. So, I always tell patients my goal is to give you information, and the decision is ultimately up to the woman whose journey this is. So, different, patients have different goals, different outcomes. The surgeries can be vastly different in terms of recovery time and time at the hospital, time away from work, time away from family. And so I think all those things have to be considered when we have that discussion, but ultimately the decision is the patient's.
So if someone already has expanders in place, can they change their mind to remove them and not do reconstruction?
Absolutely. So, and typically when I see a patient who's unsure about whether she wants reconstruction, for those who are on the fence, I usually tell them the best option if you're unsure is to allow us to put in the expanders. And so what those are spacers. I tell patients they're kind of like a water balloon that we can fill up over time. Is to let us put in those spacers or expanders at the time of the mastectomy. That allows us to save the most skin, and aesthetically will give you the best result long term. And then later on down the line, if that woman chooses to abandon the reconstruction, then it's much easier to go in and take them out and then remove any extra skin at the same time. But if they were to go forward with the reconstruction, as I said earlier, that gives you the best aesthetic outcome.
So what should a patient know if they decide to go flat and not do any reconstruction?
So as I said, I think that is where the discussion is important with the plastic surgeon, because in that situation, if a decision has been made ahead of time, then typically the breast oncologist is capable of performing that surgery. We do get occasional requests for women for the plastic surgeon to do that closure, and that's absolutely fine. The only caveat is, again, aesthetically, if you were to go flat and then later on decide you wanted reconstruction, it's a bit of a less aesthetic result. So that's just the one thing I tell patients to keep in mind.
Mm-hmm. So are only mastectomy patients eligible to have breast reconstruction surgery?
No, so as I said earlier, typically patients who undergo lumpectomy and radiation therapy are eligible for volumizing procedures, meaning, if you had a small breast and you had a lumpectomy and now there's this noticeable size difference, we can perform fat grafting to the operated breast. Other times we may want to do a reduction on the untreated breast or a breast lift. So there's always surgeries available to women who have a size or noticeable size difference between breasts after breast conservation therapy. The main thing to keep in mind there is, again, we want to wait until all the adjuvant treatments, whether it's chemo or radiation, et cetera, have been completed before we undergo treatment for those patients.
So how long will it take to complete my reconstruction, the whole process?
Excellent question. So I usually tell patients, you're going to get to know our office pretty well as a plastic surgeon. You probably will spend more time in our office than any of the other offices in kind of that first year or two soon after your mastectomy. So I tell patients typically it's about 2 to 3 surgeries over the course of sometimes 1.5 years. And the reason for that is multiple. So typically for us, the first stage is to put in those expanders at the time of mastectomy. And depending on whether you need chemo or radiation, that can delay the next stage of surgery. But even in someone who doesn't need any of those adjuvant treatments, we typically like to wait about 6 months between putting in the expanders and then doing the next stage, which again is based on the patient and would be either using implants or your own tissue. So that's 6 months. And then typically after that point, we like to wait at least another 6 months before we go back and do any revisions which might be necessary. And that might be removing some extra skin, that might be doing a breast lift on the other side, or a breast reduction on the other side, or might be little adjustments in terms of adding some fat to some areas, changing the implant size if the patient's not happy. And so, that's, like I said, about 2 to 3 surgeries over the course of 1 to 1.5 years.
Thank you. Are there any long-term effects that can affect my daily living?
I would say the vast majority of breast reconstruction patients do not have any long-term effects from reconstruction that can affect their daily living. Now, certainly with implants, especially more so than with using a woman's own tissue, there can be long-term surgeries that are necessary. So implants are not made to last forever, and they do have a rupture rate of about 1% per year. So especially in younger patients, you are guaranteed to at least go through a couple of sets of implants over your lifetime. And older patients might only need one or might need, a couple. And so there might be more surgeries, and certainly surgery has risks, but I would not say that there's any long-term effects of reconstruction that would be untoward.
Okay. Thank you, Dr. Fadis. So we will now discuss genetics with Brian Bisson. First question, what is genetic counseling and who are genetic counselors? Who are you?
That question a lot. So genetic counselors are healthcare providers who help families determine if there's a genetic disease in the family. So as a cancer genetic counselor, we meet with patients and families to find out if the cancer in their family could be hereditary. So the actual process of genetic counseling is asking a lot of questions about the patient's history, about the family history, and then sometimes we'll use genetic testing to help us determine if it's hereditary or not.
Okay, so what are the benefits of genetic testing?
So for patients, I always talk about short-term and long-term benefits. So short-term, Dr. Ram and Dr. Constantino were talking about this, is that it could change their treatment and their surgery. So if a patient can have a lumpectomy, but if they're at a high risk of having another breast cancer in the future, then they may elect to be more aggressive with the surgery. And it may also change the medications that they're given for their current breast cancer. More long-term, it can also give the patient a better idea if they're at a higher risk of having another brand new cancer in the future. Because if this first breast cancer is due to a gene, then that same gene could cause another breast cancer 10, 20 years down the road. And then the biggest concern for a lot of our patients are their family members, because if their cancer is hereditary, then it could definitely be passed on to the other relatives.
Okay, so does insurance generally cover the cost of testing?
By the time they get to our office, yes, but we're only seeing a very small portion of patients, because if you look at all breast cancer, only about 5% of breast cancer is hereditary. So the surgeons and the oncologists are kind of the first line, and they kind of look at the overall history in order to determine who's more likely going to have a hereditary form of cancer. Then they get referred to our office, and then usually genetic testing would be covered by the insurance.
So this is a funny question, but a good one. Do genes cause cancer?
Short answer is no. So that's kind of the big misunderstanding is, first of all, only about 5% of cancer is due to your genes. And then even when we talk about breast cancer genes, we all have breast cancer genes. We all have colon cancer genes. These genes are actually supposed to protect you from that type of cancer. So breast cancer genes are supposed to protect all of us from breast cancer. What that little small hereditary group has is a gene mutation, or kind of like a typo in one of those genes. So instead of the gene protecting you from cancer, that gene mutation turns the gene off. And that's what's getting passed down from generation to generation, is a mutated gene that just can't protect those individuals.
So if someone tests positive, does that mean they'll definitely have cancer?
No. So every gene has different risks associated with it. But think of a gene mutation like a risk factor. So we all know people that smoke but don't have lung cancer. Same thing here. These gene mutations increase the risk of having cancer, but it's not 100% usually that they will. And that's why it's important to discuss this with a genetic counselor or your physicians, because every gene has different risks associated with it. So a lot of you have probably heard about the Brca genes, which the risk for those people can be 60, 70, 80% to have breast cancer. But a lot of other genes, the risk for breast cancer may only be 20 or 30%. So that's why even if somebody has a gene mutation, we don't want to treat all of those people the same way.
So this is a typical question. If we have a mutation, can you fix it?
Not right now. So there are some kind of trials going on with gene therapy. So we hope to be able to change that gene back to normal or to insert a new functional copy of that gene into your genome. But for cancer, it's just too complex to do it at this point. So hopefully sometime in the future, but not right now.
So what can someone do if they are a high risk for cancer?
Right, so we usually talk about a couple different things. So increased screening. So that could be doing the typical screening that we usually do, but maybe doing it more frequently. We also talk about certain medications that these women can take to decrease their risk of breast cancer. Or as my colleagues have talked about, maybe doing a preventative surgery. So some women, if they're at a higher risk of having breast cancer, don't want to think about it or don't want to wait for the cancer to occur, and they can do a preventative surgery to prevent that from ever occurring in the first place.
So if someone has a genetic mutation, what other family members could be affected?
The short answer is anyone that you share blood with. So you could go out to your third cousins, and if you have a gene mutation, that third cousin could have the same gene mutation. The longer answer is the closer you are to that individual, the more genes you share in common with them. So we usually start with the immediate relatives, so the parents, the siblings, and the children. So we share about 50% of our genes with those individuals. So those people we focus on first. And then once we try to find out which side of the family that gene mutation is coming from, then we can inform those aunts, uncles, cousins, distant relatives about, hey, I have a gene mutation and it's coming from my mother's side of the family. And if you're my mom's sister, then maybe you should think about having genetic testing.
Thank you very much. Very informative. Next, we will be moving on to our nurse navigator, Marcy Pegg. Woohoo, extraordinaire. So, what is the role of a nurse navigator?
So as a nurse navigator, my job is to ensure that your treatment plan stays on track and kind of goes off without a hitch. I'm in constant contact with your surgical oncologist, your radiation oncologist, your medical oncologist, any scans that they've ordered, try to keep it all in line. Certain scans need to come before certain appointments. So I just basically try to keep you on track. When you're first diagnosed, it's pretty overwhelming and there's so many things they want you to do right away. So I make it my job to kind of make that easier on you by getting those things scheduled for you, getting them all planned out so that you're able to just kind of focus, just show up when I tell you to, we'll get you on track and we'll get your treatment plan going.
Okay. So how can you help us when we're there? What do you do to help us?
What can't I do?
I know.
No, so Jackie kind of said earlier, you know, I like to cheer you guys on. I'm there to talk. I'm there to help you get those scheduling. Sometimes you're like, hey, I've called to get this. They can't get me in for 3 weeks. And then I'll call them and say, hey, that's not going to work. And then, you know, I'll call you back and say, hey, they can get you in next week. So really it's to just kind of make sure to knock those barriers down. You know, like I said, it's very overwhelming. So with that extra time that I have, those resources, I like to try to help you get scheduled. If you have billing questions, I can get you the billing department, FMLA paperwork. If I can't do it for you, I will find someone who can. So really, I like to be that one resource. You know, you can come to me, and if it's not me that can solve the problem, I will point you in the right direction, or I will find that person to solve the problem for you.
Yes, she does. So how long will a patient have access to a nurse navigator?
Once you're diagnosed with cancer, you are assigned a nurse navigator. I'm with you for your active treatment. So if you're getting radiation, surgery, chemotherapy, I'm there for you. Once you are on surveillance or in survivorship, you still have access to me, but it's more of a backseat that I take. I'm here if you need me, but I'm not more in the forefront. When you are on active treatment, I try to come to your appointments with you. I try to visit you while you're in the infusion area in case you have questions or concerns. So once you're kind of through that and into your survivorship mode, I'm just there if you need me, a friendly face to say hi, but you can always call and reach out to me as long as you're with the cancer institute.
Yes, we have her number. We do. So what is the role of nursing in my cancer treatment?
Well, during your cancer treatment, there are many, many nurses that are part of kind of what keeps your plan on track. You'll have your infusion nurses if chemotherapy is part of your plan, and those are the ones that are going to be infusing the medications, talking to you about your chemotherapy. Should anything happen while you're being treated, they're the ones to take care of you. You have your clinic nurses. Every doctor has a clinic nurse that nurse can help you with medication refills, side effect management. Also, if you just kind of need to talk or you have questions about your treatment role. You have me, your nurse navigator as well, and we kind of all work together as a team. Now, if you call me and ask me a question that normally a clinic nurse would answer, of course I'm going to answer it. You would call your clinic nurse and ask them a question. You know, we're all a big team, so you have many different nurses that play many different roles, but ultimately we're just here to support you through everything.
So if we have it, you kind of answered this question, but I'm going to ask you again, because from this point, I have a concern about my treatment. Do I call Marcy or do I call Leslie? You know, that's what I do. Who do I call? Which one first?
So generally, if it's a symptom management question, medication refill, we would say, hey, call your clinic nurse. However, we're a team, especially the team I work with. You know, we're all in this together. We're all here together. So anything I can answer, I will get to the right department. So really you could call your clinic nurse, you could call your nurse navigator. We all work together to just make sure that you get taken care of at the end of the day.
So if there's a non-emergency or urgent question, what is the best way to get it answered?
Orlando Health went to Epic in April, and we have a fabulous feature of My Chart, and you can sign up for My Chart. If it's not urgent, if it's something you're like, you know, I just want to kind of get this question answered when they have a minute, send us a message through My Chart. The clinic nurses have access to it. We all have access to it. We can read your question, write you back. I know that when you're assigned to me as a navigator, I do give you a business card, and that has a phone number and an email on it as well that you can email me directly through there. But I think that the My Chart is probably easier because there's multiple people that will check that inbox. So it's nice, you know, if I'm busy or if, you know, Leslie's like, oh, hey, someone wrote me a question, you know, I'm going to answer this question. I can get back to them when she has a minute versus a phone call. Now, of course, if it's urgent, it's something that needs to be addressed immediately, please call our office. But if it's something you just kind of want to know and you just need some help with, I think the My Chart feature is super.
So what are the resources that you can provide for my family? Because they walk this with us.
So we do at the Cancer Institute, we have a robust cancer support community, and all of the resources that are available through our cancer support community are available for our patients as well as their caregivers. They do art therapy, music therapy, jewelry making, yoga. They have counseling that's available if your family members may be having a little bit of issues with, you know, dealing with your diagnosis as well. They have counselors that can speak to you as well as your family members. I like to talk to your family members as well. They can always reach out to me. I usually give a business card to the patient as well as their family member and say, hey, give me a call as long as your family member's okay with it. I'm here to support you as well because, you know, on your journey, you're going through it, but your family members, especially the ones that are closest to you, are also going through this journey. And so we're here to support you as well. We're a whole unit.
Yes, you are. And you're part of our family now forever. Thank you. Last but not least, our lymphedema specialist, Megan Euler. So, Megan, let me find your question. What is lymphedema?
Lymphedema is essentially swelling that can occur on the side that the cancer was, or was appropriately there.
Yes.
So that can happen in the arm, in the chest, in the trunk, upper trunk area too.
Okay, so what is my chance of getting lymphedema?
That varies from patient to patient. Usually the more lymph nodes that are removed, the higher the risk for lymphedema. If radiation therapy gets added into that, the risk goes up even a little bit more because it can damage some of the remaining lymph nodes that are left behind. Statistics currently are stating that 1 in 5 breast patients will have some issue with lymphedema.
So what are the signs and symptoms?
Swelling is a big one, but before we can even see it, a lot of times patients will experience heaviness or tightness in the arm or even in the breast. So those are the two biggest things that we educate to watch for. And then that's where we can jump in and start early and keep it managed well.
So how do you treat it? And will it ever go away?
We use a variety of methods depending on what kind of stage of lymphedema you're at when you first come to see me. If it's early on, we do a lot of manual lymphatic drainage, which is a special massage to the area. We reroute that to different intact lymph nodes in the body. We use compression garments. If you have a lot of swelling initially, we'll do bandaging to reduce and then get you into a compression sleeve. Sabina is where it hurts. As a form of management. And then there's always stretching, good skin hygiene, and exercise.
So speaking of the compression, does that need to be worn forever?
It depends. A lot of times compression will be a part of your life from that point forward. So in some cases, we can definitely use it for only certain activities that irritate the arm at the time. A lot of that could be like gardening or more strenuous type of activities. We usually do recommend it if you're on a long flight, things like that, just because the pressure changes can affect swelling and it can cause a flare of lymphedema. So it varies, but it will usually be a part in some capacity.
Can therapy help if there is tightness in the arm, shoulder after surgery and other cancer treatments?
Yes.
I know the answer to this.
Yeah, so lymphedema is kind of one of the main things that I see, but I also treat if there's any tightness or loss of motion within the shoulder. So we do a lot of stretching, not torture, stretching.
Torture.
We try to reduce some scar tissue that may have formed as well from either the surgical treatments or radiation, things like that. So if I don't treat that, there's also other therapists or other occupational therapists and physical therapists that can help improve range of motion as well. We can also see some balance deficits sometimes following chemotherapy. If there's the neuropathy that was mentioned earlier. There's different treatment methods that we try to help patients get back to the most normal that they can be again.
So therapy can help any other side effects from surgery? All the above?
Pretty much, if it's something that's physical. So like I said, sometimes there's balance issues. Chemo brain was mentioned, so sometimes we can encourage some cognitive type therapies as well if needed. Yeah, therapists are pretty awesome and we can help a lot.
Yes, they are. Thank you, Megan. All right, so now we're going to open up the floor for any additional questions. I know someone was monitoring the questions on Zoom.
Okay. Thank you. I'll be right back. Okay, so we did get some questions online. One was, this individual heard in the introduction that it was mentioned that 85% of breast cancer occurs in persons without family history and occur due to mutations and life in general. What type of lifestyle changes are recommended to assist in prevention?
Straw here. So things that are just generally healthy for individuals can also help with decreasing cancer risk, especially breast cancer. So living a healthy lifestyle, being physically active, achieving your ideal body weight or not being overweight, limiting alcohol, things in moderation is what I always say. I don't think you have to be vegan or make drastic changes, but I think less processed food, avoidance of chemicals, more clean eating are some of the things that can help with that. Hormones are one of the risk factors for developing breast cancer, especially hormone driven. So if you need hormone replacement therapy at the time of menopause and you haven't had breast cancer, then using the lowest dose for the shortest amount of time will help to limit your risk of developing breast cancer.
Anyone else? No? Okay, one more question we received. Was this individual, I thought I heard either Dr. C or Dr. Swanek say earlier that the old recommendation for follow-up scans every 6 months was no longer recommended. For one reason, due to exposure to radiation. But Mr. Benson stated that if a person tests positive genetically, that the recommendation is to keep with typical scans. If you are genetically positive or predisposed, wouldn't doing typical scans also increase exposure to radiation?
Very good question. So what we're looking at is a risk benefit ratio. So if you have a genetic mutation where you're at increased risk of ovarian cancer, you may be doing ultrasounds, pelvic ultrasound to look for a mass or a lesion. But in most women who don't have a genetic mutation, we're not doing PET scans or CAT scans. We are doing breast MRIs, mammograms, ultrasounds, and appropriate screening. I don't know if that answers the question. I don't think so. We got 3 hands up.
At least for the person online.
I just wonder, what made you all go into this field?
We're glad you did.
That's a great question. I think we all feel driven to be, I think we're all called to be in this field because we find it rewarding. We enjoy helping people and through a difficult journey. A lot of people will say to us, isn't it depressing? Don't you feel depressed? But it's not. I mean, we really have a very driven population that wants to get well, and we want to help you on that journey. Hope anybody else wants to say.
Hi. Jackie, you did a wonderful job. Jackie's been my best friend since I was 3. So as a woman who has never had children, am I at higher risk of developing breast cancer?
Yeah, it is one of the risk factors, but it doesn't mean that you would develop breast cancer. So things that help to, that are supposed to help limit your risk are having children before the age of 30, having late onset of menses or your periods, having early menopause, breastfeeding, not taking hormones like birth control pills or hormone replacement. But we can have people that do all of the things that, are low risk and they still get breast cancer, or women that have all the high risk things and never do. So they're just risks.
Okay, let me do first and then I'll take this one.
I'll be going through reconstructive surgery soon. And just wondering, the worst thing to do is to read on the internet and get information. But I read that if you have a, what is it called? Okay. If you have a breast reduction, tissue is removed, and that reduces the risk of having breast cancer in that breast. Is that true?
So specifically going back to a breast reduction. Yes, so good question. So yes, anytime you remove breast tissue, so as in a breast reduction, there is breast tissue removed. So in theory, yes, that would decrease your risk of breast cancer. I don't know that there's any good studies that have shown by what percentage. But you can imagine, again, if you remove some breast tissue, that tissue that's been removed no longer can turn into cancer. So
Let me
This is for Dr. Beatus. What is the risks to replace an implant after someone's been double radiated?
That's a great question. So anytime a patient has radiation therapy, the risk of going back and doing any kind of operation, especially with implants, is risky. So I always warn patients, unless there's a real problem like a implant rupture or severe pain or contracture, we try to limit the amount of times we go back in on radiated patients. Now, as Dr. Swanek pointed out, radiation changes differ from one patient to another. So some we see and they have very minimal changes to almost no changes, and other than, like you said, the little dots from the simulation, you can't tell that they've even been radiated. And others come in and they look like they've been burned. So you have to take that factor into consideration as well. Good question.
Dr. Constantino, I was on tamoxifen, and my girlfriend told me I was having hip problems, one hip, my right hip. She said, everybody I know that was on tamoxifen had hip problems. So at 4 years, I quit taking it. And then she yelled at me for not taking it for the whole 5 years. But I'm wondering if that's what's causing my hip problem. I have an x-ray from 4 years ago of my hip when it first started bothering me. And I have an x-ray from this last month because I'm going to go to see an orthopedic surgeon. So I'm just wondering if the hip problem could possibly be from the tamoxifen.
I don't think so. The Arimidex and Femara can cause joint pain, joint stiffness. People say when they get up, they feel like they've aged 10 years. By the way, I may have that secondhand as well. but tamoxifen doesn't tend to, and especially in an isolated location, like one side of, one specific joint, I think that's probably more likely to be arthritis or bursitis, or
they say it is severe arthritis.
Yeah. Now, the advantage of tamoxifen, besides the breast cancer benefit, is that it helps to build bone. So if you have osteoporosis or osteopenia, it helps with that as well. I don't think that the tamoxifen is probably causing that, with the limited information I know.
Hi, I have a question. Is it Dr. Betas? So, if you've had radiation and you're as hard as a rock, and the recommendation is that they should take your own body's fat or muscle or whatever to replace it rather than to have an implant because it won't work. You had mentioned earlier that in a lumpectomy, sometimes you inject fat cells and things like that. So why is that not an option instead of having surgery from, left to right and then trying to heal from the breast surgery and also from, is it flap, some deep flap? And then of course, if the back muscle or the thigh is not an option, that doesn't seem, especially if you're a diabetic or had other issues, that doesn't seem like you'd want to have to do that. So then if you remove the expanders, would that change the effect of what the radiation has already done to you? I'm sorry, that was two questions.
A
lot of questions.
It's a good question. So to answer the first question, fat grafting versus using kind of a flap, as you said. So a flap is where we move a large portion of tissue from one part of the body to the other. And so that, as I said, that allows us to move a significant amount of tissue, and that's either skin and fat or skin, fat, and muscle. And the reason maybe that wasn't recommended in some situations is fat grafting allows us to move smaller portions of tissue. And typically requires multiple rounds. So fat grafting would allow us to do a little bit. It typically has to be repeated multiple times if that's something you want to do for whole breast reconstruction. We do typically perform fat grafting for patients who have had implant-based reconstruction because after the breast tissue is removed, there is very little skin and fat covering that implant. And implants ripple and not a perfect round breast shape. So we like the fat graft on top of that, again, with small amounts to cover those ripples and those wrinkles from the implant. So that might be the one reason, that might be the reason why we would recommend, a flap, which is again moving a large portion of tissue versus fat grafting for whole breast reconstruction. And then your second question was about the expander. I'm not sure I answered that question.
So let's say you decide you don't want to do the reconstruction and you have to expand something. So the effects of radiation as you have now, would that make any difference? Because you have to expand and remove because, I mean, it's not the expander that's part of the rock, it's.
Correct. Yeah, so that would not make a difference. No, the expander is just there to hold the space, and we typically use that to stretch the skin in preparation for the second or permanent reconstruction.
So what's there now cannot be removed after the part of this or.
Not without a major, like a flap, as I said, where we can bring fresh skin in either from your back or your abdomen or the thigh or the buttock area. So we can bring fresh skin to that area. Then we can remove part or all of the radiated skin on the breast.
Get her now. Give you a second.
Hello. Does a person that have breasts that are cystic, does that usually eventually turn into breast cancer, cysts of the breast?
No, it is not a precursor of breast cancer. Sometimes patients present with cysts and we find a cancer, but they're not really related.
Does having breast implants increase your potential to have breast cancer?
No, not that we know of.
This is your time right here. What? Oh.
I'm gonna try to ask the question. If you don't have cancer, but you go to do the test every year, and every year when you do the mammogram, like with my situation, every time I do the mammogram, after that they ask me to do ultrasound. So why would they, since my history, like every time I do the mammogram, I end up doing ultrasound. Why they don't go straight and do ultrasound instead, doing the mammogram, then the ultrasound?
Those two tests show different things. So mammogram is still the best screening exam for early breast cancer because calcifications and small masses can be seen. Ultrasound needs to be a targeted exam looking at specific areas of the breast that might be of concern. So putting them together is the best approach.
So that would be a diagnostic study if you did, and your doctor could order it that way as diagnostic. It can have insurance implications, like screening is covered and sometimes diagnostic there's a fee for based on your insurance. But if you're finding that every time you go you need the ultrasound, they could order it that way.
I remember in time always the mixed tissue. That cause cancer?
So with,
The thick tissue.
density, the mammogram is less accurate, or it can obscure some of the abnormal findings, and so the ultrasound helps increase that accuracy.
She
So that's probably why. And
she was asking if the thick tissue could cause cancer.
it is a risk factor. Yeah,
It's a
increased
risk.
density is a risk factor. Doesn't cause it per se, but it is.
That's why they want to always.
Correct.
Okay. Yeah.
Outside of symmetry, when you have a mastectomy on one side, can you do the breast reduction and lift all at the same time when when they're putting in the implant, and then have the breast reduction done on the existing breast?
So typically, first, and this is for me a personal question, I guess, I prefer to, or surgeon preference, I should say, I prefer to do the contralateral procedure at the time of the permanent reconstruction, unless you're having a flap. If you're having a flap, we prefer to do that, wait until the tissue settles, the swelling goes down, and we have a better idea of your final size and shape before we then go back and stage the contralateral, meaning the opposite side breast surgery.
Both at the same time.
If you're having an implant, you can't.
Okay. One more question, and then we're out of time for questions.
If you have calcifications and that shows up in you have to go back every 6 months to get, another view. Does that indicate that, potentially, especially if you have breast density, could that be an indication that, you could get breast cancer? Because I understand a little bit about the calcification, but I was just wondering if that's like a indication.
Well, calcifications can represent benign disease. They can calcify in blood vessels, in scar tissue, in ducts that are benign. So the benign ones aren't going to become malignant. What happens is cells can overgrow in the ducts, and then when they overgrow too much, they necrose, and that causes calcification. So it's the new calcifications developing that would be suspicious. But just having calcifications doesn't increase the risk of it changing.
You are back here.
Yes.
Oh, I'm sorry. Were you able to answer a question? Okay, sorry. Okay, 2 more from our virtual attendees. Approximately what percentage of women treated with, and I might say this wrong, aromatase inhibitors, okay, experience significant side effects? How might drug therapy change them? Specifically, I'm asking about heart disease.
I don't see a lot of heart disease with aromatase inhibitors. Some women who take aromatase inhibitors, that's like Arimidex and Femara, they have no side effects and tolerate it very well. Most women, I would say, have some side effects, whether it's joint stiffness, hot flashes, things like that. It can also decrease your bone density over time. There can be some effects on cholesterol and blood pressure that can relate to heart disease, but those tend to be things that we can treat as we treat in people without breast cancer.
Thank you. And one more for Marcy. What certifications does it take to become a nurse navigator, if any?
For nurse navigator, at least with Orlando Health, they require you to have your bachelor's degree. You should have some sort of oncology experience, and within a year of becoming a nurse navigator, you should have your oncology certification, your national oncology certification as well.
Thank you. Very good questions. And let's thank our panel very much. My journey has gone down every one of these roads. So this is a picture of what your cancer journey looks like. And I am so grateful for each and every one of them. So thank you, thank you, thank you. So now we're going to honor one of our team members because it's her birthday. Rosetta Newland, happy birthday to you. Yeah. Oh, and she's also a breast cancer survivor. Way to go. We are overcomers. Yes. Oh, that's very sweet. Okay. Now it's time for the drawing, the giveaway. So pull out your tickets. Sure, sure. Oh, Erin Hoover. And she just left. Yes, she is. That was funny. Terry Wales. Woo, Terry! You are the winner. Okay. And is that it? So this concludes our Breast Decisions 2021. We are so glad that you all came and so thankful for all of our experts to take their time and answer our questions. And thank you everybody who is online that was able to join us. Remember, Monday you will get an email when in the subject line, it'll say Breast Decisions 2021. So look out for that and have a wonderful day. Bye.